I'd like to go ahead and introduce our next presenter. Vanessa Sanne is a nurse practitioner specializing in palliative care. She's worked in healthcare for more than 2.5 decades and oncology since 1998. Vanessa's approach to care is built on the foundation of a partnership with her patients. She is there to guide, but they are in the driver's seat. Her role is to support their decision-making, providing education and guidance to help them achieve their goals consistent with their stated values, while striving all the time to manage symptoms associated with their disease and treatment. Let's welcome Vanessa Sanne.
Hello, and thank you, Paul, for that introduction, and Brian for the amazing content that you laid so lovely. It is the foundation to the work that we do, and I'm so honored to be in partnership in the community with people like Brian Leese and Kelly Ambrose, who you'll hear from after me. I feel like sometimes when you look at patients with very high complexity and things that are really challenging for our current medical systems as they exist, palliative care and hospice are kind of a repository or incubator, as you will, for these complex medical system situations, and often with poor or no guidelines for how to do these things. So we really are working at pulling out threads from other experiences and trying to apply them in these unique cases. And it's really hard work. I just want to acknowledge that it's difficult and challenging. And even for somebody like myself who does this work, listening to those case studies with Brian, left me feeling a little bit kind of tight in my belly. So I can imagine if it's not something you do all the time, that this would be a bit overwhelming. I want to just kind of start with my personal story. I've been a lifelong medical care provider. I started working in long-term care when I was 15, and I have always worked in medicine ever since. And so my lifelong love of medicine and then some threads of my personal story are part of what landed me in this place of really trying to develop a trauma-informed care model. So I have a couple of you got my introduction that I'm an oncology nurse. I've been in oncology since 1998. I started in some pretty intense work in patient pediatrics, and the reason I pull that in is that the communication training that's required to talk to ill children, and particularly their ill parents of ill children, is a part of the foundation which allowed me to, I believe, develop this work that I do now. And I've always had a very strong interest in a patient's narrative. What is the patient going through, and what is the context of what we are working with? And I'll also include some of my personal background, where I've been married for 25 years. We had a couple of bio children, our 2 boys. We adopted a couple of children from Haiti. And that was really a turning point for me, both personally and professionally, because I had to become more aware of implicit bias and systemic racism and things, because we are now an intercultural family. And because one of my children came from a really hard place, I needed to acquire trauma training. So we had some pretty significant early childhood trauma that entered our home, and it was required to get training. It was interesting how, there was just a paucity of training at the time, and that was 14 years ago. Now there's a tremendous amount more, but the things that I learned in my trauma training really informed the care that I started doing in palliative, recognizing that there were similar themes that presented in terms of behavior and attitudes between my traumatized child and some of the patients that were sitting in front of me in my clinical practice. So that rapidly accelerated my learning curve in this area of working with people who have often their own trauma, and it often includes substance use disorder, but not always. So I want to kind of build my presentation around cases. I know, Brian just spoke of a couple of cases. I want to do the same thing. I want to start with a case that did not have the outcome I was looking for. I want to take something, that's kind of blurry and really focus in on what are the elements and what were the considerations in terms of the decisions that were made at the time. Because I think in hindsight, Brian and I can both attest to looking back and thinking, gosh, what were the learning opportunities? How might we have approached that differently so that we can apply that to the next patient that comes, because there will always be a next patient. So I want to start with, we're going to call her Lisa. We're protecting her name for, privacy. A 26-year-old female that presented to me with locally advanced cervical cancer, and it was pretty aggressively locally advanced. It was bulky disease, and cervical cancer tends to be quite painful. So her plan for treatment was a combined chemotherapy and radiation plan with the intent of cure. And I absolutely adored meeting this woman. She was so full of energy and so full of life and so enthusiastic to, kind of just wake up each day. And it was a fascinating thing to partner with her. She had a very long-standing history of substance use disorder, starting with her parents who gave her heroin at age 10, which is just like, if we pause for a second there and think about that, her brain had never not known, heroin and what it was like to have heroin integrated into its development. And that's a theme we often see with patients with substance use disorder, is that we've got the, developing brain exposed. And when we start thinking about SUDs as a chronic illness, you really need to start thinking about those kinds of pieces. And it just kind of flavors your individuation, really thinking about what must it have looked like at 10 to be offered heroin. And how might that impact a person's ability to think, function, and learn effective coping? So when I met her, she had been 3 years into a disease-free state or substance-free state. She had gone through a court system and actually was not incarcerated, but went through some state-mandated treatment. And she was so proud of this achievement of having been substance-free for 3 years. And she was very, very worried about the amount of pain she was in and the potential for kind of relapsing into these old patterns of behavior and this kind of biology that had been built into her brain. And one of the other things that I loved about her, she was just so open and engaged in communicating these things. And I want to take a little bit of credit in saying, my approach with this is really to create a safe space for patient to explore, asking non-judgmental questions and really allowing the patient to share their narrative, so that we can find those kinds of threads that we can build trust with. So often a theme with patients with SUDS is this kind of self-perpetuating, not by the patient, but by the medical system, patterns of behavior that just sow in mistrust over and over and over, and Brian spoke a bit about that early on in his narrative. And so those building blocks that he spoke of individualized, empathetic care is really important. And starting with the allowance of the patient to tell their story is where we start that. So she had this pain. By the time she came to me, she'd gone through some diagnostic, and some other providers. And so she'd been provided some medications. She was given oxycodone, some gabapentin, Celebrex, and she'd been using those things at the time we met, but felt like her pain was just not super well managed. So the things that Lisa had going for her when we met were that substance-free at the time of our working relationship was such a motivator for her, and it really allowed her an opportunity to be vulnerable and to explain what was most important to her. It really helped her focus in on her goals. So for allowing patients to kind of set those goals in front of us and working towards those goals together, or finding ways to unify with one another. For her, it was maintaining this period of time in her life where she was not using substances. She had incredible self-awareness. She'd gone through this really intensive work in the last few years, and she was very aware of her own triggers, and she was open in saying, my number one trigger for what she would call relapse would be withdrawal. So whatever we do, I cannot be in a situation where I experience withdrawal. I know myself, I know my limitations, I will go back to using in that situation. So it was really nice to be able to kind of identify, hey, this is a thing that we need to avoid, and then build a plan around it. So she seemed at the time that we met to be managing oxycodone okay. We kind of talked through, her recollection of how she was using those meds, and I was kind of calculating a pill count based on her PDMP report. So just initially kind of figuring out, is her narrative matching what the medical data says? And that's kind of just a point of kind of helping to define whether the awareness of what she's doing is actually reflected in the data. She was open to safety plans around medications. She was open to conversing about what her triggers were, what we kind of defined as safe opioid use. She was open to small prescriptions. She was very open to urine drug screens. She was getting some of those externally as a part of her program anyway. She had really good support. She had articulated that she had very good support through state programs and people in her just in her life outside of clinic. She was living in a sober housing facility. So we had to really build safety plans around that as well, because having opioids in a sober housing environment had its own set of complexities, which required some communication with the house manager and how we were going to manage having those opioids locked up and dispensed and that kind of thing. And she had a sponsor for her particular method of staying substance free. And then she also had been given some career assistance and had just started a brand new job. And turned out that was going for her, but it ended up being kind of a complex part of her care. So she really kind of walked through the door with some great assets to work with, if you will. So we started kind of with a delineation of duties, she and I and the other players in her medical team. So the gyn-onc, the rad-onc, we had the home care plan, and we'll talk about that in a minute. But we upfront were really communicative about what were the roles of each of these members of the team and where were we going to boundary those, and how were we going to expect communication to take place around those things, so that we had a safety plan in place with her opioids that would be consistent amongst the whole team, that if there were concerns or worries about something that was identified, they would know who to communicate. And I was the person that was taking on the prescribing aspect of her care. And it was just really great to have this kind of open communication amongst the team. We have an embedded palliative care model, which is so lovely because I can literally walk down, 2 doors and talk to her medical oncologist and pop down the stairs and talk to her radiation oncologist. And that allows that communication to be fluid and in real time. We wanted to really emphasize using non-opioid medications as much as possible. We called it layering the onion, where we're kind of using all these different things, and at the very center is whatever opioid would be required to manage the rest of the pain. So we kind of changed her NSAID plan. We incorporated Tylenol. We added an anticholinergic because she had the spasmodic quality to her pain. She continued on the gabapentin because she had this really complex pelvic pain syndrome, which included neuropathic pain. And we talked about various ways that we might approach the opioid part of her pain management. And I was most comfortable with using methadone in split doses because we would have that kind of analgesic effect with a lower risk. And she was incredibly opposed to the methadone. And so it's part of my approach with patients is to make sure that they buy into the plan, that they feel like that they have a stake in the direction that we go with their care. So we talked about starting a transdermal buprenorphine. And at that time, I had not used sublingual buprenorphine or Suboxone. My comfort level was with transdermal. And this was ultimately not something that was approved by her insurance carrier. So I kind of explored community resources for helping me figure out, could we use sublingual instead of transdermal? And I just didn't end up having a confident support source that would allow me to begin prescribing something that I was unfamiliar with to a patient that was this high risk. So we decided that we were going to be unable to use either the methadone or the buprenorphine. And so we decided that transdermal fentanyl would be the next safest option. And that may seem a little bit counter to some of you who don't use transdermal fentanyl, but it is something you can observe the patient using. You can schedule visits for changes of patches. There are ways to enhance the safety around that in a way that you sometimes are challenged with pills and tablets. So we ultimately decided on fentanyl with oxycodone, but a reduced amount. And then we called in our community palliative support team, and Kelly Ambrose is going to speak to this after myself, but essentially it's a interdisciplinary community-based support team, and they are absolutely my right hand when it comes to complicated cases in the outpatient setting and being able to build safety plans that are, monitored, for lack of a better word, and supported by people in the community when the resources in the clinic are low. So what ended up happening is Lisa presented very, very functional. As we started to get into her treatment, we started to see that there was a little bit more chaos behind the scenes, and her ability to follow schedules and instructions, even in written form, where she was really challenged by this. So she struggled with a 72-hour change schedule, and out of fear of that withdrawal, she would double up on her patches. And then when we started to try to kind of taper that back down to the lower dose, she would have these withdrawal symptoms and she would put another patch on. So she ended up on a much higher dose than we had originally intended. But we had this period of time we were trying to get her through treatment. And so we kind of held that dose and tried not to have it increase, and we set some boundaries in place. And it was a bit of a challenging experience because her ability to manage these meds was challenged. And it turns out she didn't have the support in the community that she had originally kind of articulated. That support dissipated in the setting where she was using these substances, even for a legitimate medical concern. So that was a real challenge. She had some difficulty following up with her appointments as she got further in, and we learned that part of that was her distress over her disease. Part of it was her desire to keep this new job that she'd gotten, and she really, really wanted to keep it. There were transportation barriers. There were just kind of all kinds of layers that the further we got into her treatment, the harder it was to kind of maintain those safety plans that we put in place. And ultimately, in the midst of this chaos, Lisa returned to using drugs from the street, non-prescribed substances. And so at the end of her treatment, her goal to go back to a state of not using substances was very high. She really wanted to engage in that, but she was also very boundaried around how she was willing to engage in that change. And so we worked so hard trying to find a program or a situation that would work for her. We wanted to get her on, medication therapy. She did not want to go to methadone. That remained kind of an anchor point for her. So we had talked about the possibility of a microdose rotation to buprenorphine. And I cannot tell you how many hours myself and the community team spent calling and contacting and trying to find the right setting for her. And it just, between the barriers of HIPAA and getting paperwork to the right place so we could even communicate a potential, hypothetical situation, it just took a really long time and a tremendous amount of effort, which I feel like is a systemic failure, if you will. She wanted to go to OHSU. She had heard she could go into the hospital and detox. She was willing to detox in an inpatient medication, monitored setting, and she was twice sent to an outpatient once a methadone clinic and once an outpatient kind of detox center, but that didn't have the support that she was looking for. And so eventually Lisa was lost to follow up. She did pop up several months later with a recurrent disease that is now incurable. And she disengaged from our team and declined to come back to our office for care, which saddens me deeply. In looking at this opportunity for learning, I think, I have this kind of philosophy that there are no, failures, only opportunities for learning. I think as a prescriber, giving the choice in the very beginning maybe was a little too optimistic. That if I had said, methadone is what I think we have to do in order to manage your pain and kind of set a boundary there, I imagine the outcome would have been different. I don't have a crystal ball, I don't know, but if I were to say I was going to do something different, I think that is what I would do. And really engage a little bit more in trying to get her supports that she had identified present and engaged in the plan, because that was a piece that was kind of missing. She was the conduit to her supports, but we didn't have a lot of direct engagement to her supports. I think the recognition that she had difficulty managing, small, even small instructions, let alone the complex instructions that came from her medical care plan. I wish there was a way to have identified that a little earlier and kind of maybe wrapped a different system around that. I'm not sure how I would do it, but just in terms of opportunity for learning. I was not directly observing her patches when she came in. And I think if I were to do this again, and I have done it again, that request of, hey, can you show me your patch on and show me that you're, rotating it around, just kind of incorporate it and normalize that, hey, this is just what I look at when you come in every 3 days. I think I would have maybe identified that patch doubling a little bit earlier. And, this is where, stronger boundaries, I think that's a challenging thing, because in these cases, you really do want to individualize the care. You do want safety plans. You want reassessment. You want those urine drug screens. They're only so helpful, but they are a tool. But we also need some opportunity to build grace in where, oftentimes what I'll do is a verbal agreement about, both of our rights and responsibilities first, and just document that as a verbal. And that way, if there's something that kind of comes up as disconcerting, then we can sit back down and say, hey, remember how we talked about this? Now let's just kind of put it in writing so that we both are on the same page. And that gives an opportunity for grace. If you're putting those things in writing right up front, sometimes that leaves a little bit less flexibility. So I think, at the end of the day, what we really need are more interdisciplinary patient-centered options. I think we could have been able to serve this patient and other patients in the situation better if we had more interdisciplinary management of these situations. So our current systems just lack this. They lack the ability to provide ethical and adequate care for all of the reasons that Brian kind of laid out for us, and more. Time. I think the thing in palliative care that I have going for me is time. That often, times I have much more time to explore these things with patients than a primary care provider, or even a substance use clinic or a pain clinic. I think in the kind of grand scheme of things, we still have a lot of bias floating around, like Brian spoke of. Our substance use clinics in this community are incredibly overburdened and ill-equipped for the nuance of somebody with a complex medical situation that does require pain management. And I would really love to have an opportunity to kind of coordinate care with somebody who could help manage a safe opioid plan and substance use at the same time. And then, our pain clinics are really designed for, not having that flexibility, or not having any threshold for kind of, non-prescribed substances. And that may be a little unrealistic for working with some of these patients in the middle of, a traumatic life event. So what I'd love to see, and I think what we need to be striving for, are more integrated systems. And I think we all agree with that. And there are places where all of these things intersect in the middle, but there are some patients it would be really nice if the primary care providers and the pain management folks could work together, or the pain and the substance use folks could work together, or just the primary and the substance use folks could work together. I think we're seeing a little bit more integration in these things, but we definitely are not where we need to be to effectively and ethically manage this population. So I, like Brian, am not a subject expert. It's part of why I started with my personal experience up front is, understanding that we're getting to this place by practicing, and it's practicing the art of medicine. It's not practicing in a vacuum, but it is a practice. We're developing strategies. We're trying to get better at it. We're trying to kind of reach for the resources we have available and kind of knit them together into something that feels right. I think we're looking for that shift and turn, and it's really hard to know how to do that. And in palliative and hospice, like I spoke before, we're kind of leaders by default. And I think the reason for that is time. We have time, more time, not enough time. And so some suggestions that I could toss out that were helpful for me, and I think would be helpful for, any person who's interested in getting better at this, are increasing your trauma-informed care practices. If you have not had trauma-informed care training, get it. And I love that Brian also included the trauma-informed care to self, because this is hard work. Working with patients that require so much supportive energy can be really hard, and oftentimes we have outcomes that are less than what we're hoping for, and that can be incredibly personally disappointing. With Lisa, it's really hard for me not to feel wholly responsible for her going back to a space where she's using substances again. And so working with a team who's helped me kind of deal with my grief and my part of that, and just the sadness that, she wasn't willing or able to come back to this clinic for whatever reasons, which I think have a lot to do with her trauma, for further care, saddens me greatly. So kind of that self compassion and working with other people who kind of experience that same thing, either with other patients or with her. Our clinic does such a beautiful job of making space for patients who come from hard places that all of the team was invested in Lisa's success. The schedulers were calling and recalling. The nurses were, on the phone all the time trying to get a hold of her. Like, everybody wanted her to show up and be successful. And so there was kind of a collective sadness at the end of the situation where we had outcomes that weren't what we were hoping. So I would suggest, that trauma training, attachment training. Now, this comes from my adoption situation, but this attachment training and understanding how early childhood attachment impacts a person's ability to relate to others later in life, hugely helpful, very empathy building. So I encourage you to train as leaders. I encourage you to get, or encourage your staff to get training so that everybody's using the same language and everybody's considering the same kinds of things. I put a few books on here that are kind of easy to get a hold of, and I would say generally easy to read. The Boy Who Was Raised as a Dog and Other Stories from a Child Psychiatrist Notebook, hugely enlightening, definitely not morning coffee reading. It's a little bit heavier, but can be incredibly informative in terms of understanding where people come from when they come into our clinic from the hard places. So I want us to consider as people who are leaders in healthcare, how we might view and treat these marginalized populations differently. We might need to restructure some of the way that we practice medicine, and this might come at a financial cost, but a gain in terms of human dignity and just the sense of doing things correctly. We might need to have longer appointment times for people with higher needs. It takes longer to build rapport for people who have come from hard places and maybe have different attachment styles or have been marginalized and treated poorly by the medical establishment itself. And what I tell people is the solutions, including empathy, is often in the weeds. You really have to get down in the weeds and understand somebody and understand where they come from to be able to do this well. So I would also encourage interdisciplinary visits for patients if it's accessible to you. I know a lot of you don't have this ability, but if you do, to see a patient jointly with somebody who can kind of see the things from a different perspective than you, that can offer context to you as a provider outside of the room with the patient, or maybe provide supportive context for the patient in the room with you as a provider. And that support, that dual role, is really effective and helpful in managing these patients that are challenging. It can reduce some triangulation. So there are sometimes behaviors in people who have trauma histories that can be kind of triangulating, and ways to reduce that triangulation and build, straightforward guidelines and communication techniques can be really helpful. And it can increase continuity of care and many other things. But I can't say enough about the importance, and I know Brian spoke to that on the hospice team, that interdisciplinary team. Everybody brings something special to the table, both to the patient and as the group, to the group as a whole. I just want to take a quick second and say the other thing that is kind of getting a little bit of prime time right now is harm reduction models, and understanding that harm reduction is good medical management of patients that have SUDs. And so we need to be thinking about exposing ourselves to new ways of thinking. And I love that you're here today, because you're doing that. So things like seatbelts, that's something everybody does. It's a harm reduction element. Masking in the community. Yes, there was a little bit of distress over, who, where, when, and how we should wear our masks. But the whole idea was that we changed a behavior to reduce harm. And there are going to be suggestions and legislations coming in the future about harm reduction methods that can be used to save lives for people with SUDs. And I would encourage you to read about them, truly understand the data and where these things have been tried in other places in the world, or in even the United States. We've got some pilots coming up, and begin to be invested in those kinds of supports for our patients. And also really thinking about novel models of patient care, welcoming integration and innovation pilot projects. We have some really positive successes at Compass Oncology, where I work, coming from pilot projects. The community-based palliative care team that Kelly will speak to in a moment came out of a pilot project of a hospice organization and our organization feeling like we needed some support for patients in between, outpatient clinic and hospice. And we've grown that into something that's really incredibly beautiful and actually being looked at nationally. We did an opioid safety, we had a grant to investigate opioid safety in our clinic, and part of this ability to manage patients safely with opioids and substance use disorder came out of that pilot project, and really identifying, we didn't even have any idea how many patients were walking through our doors that had, substance use disorder as a commingling challenge to their cancer. We were very focused on cancer. Now the doors are open and we can't go back. We can't ignore it. Now we have to integrate it into part of our care for patients. And I want to just shout out and say I've really been proud of the providers in this clinic who have worked hard to kind of be like steep learning curve, understand, and work integrative with the palliative care teams to meet these needs. So, we need data to support new care models, and that data may not be these very large studies that we're used to doing. They may be small pilot projects that we kind of have to shift and pivot and change over time. And looking at that data, making sure that the narrative is associated with the data is really important. And I think Kelly will speak a little bit to that today in terms of the community-based team as well. I'm going to set up quite quickly a case study that is going to be started by me, and then Kelly will speak to it, and then we'll come back around to Brian, who will speak to this person. This gentleman's name is Aaron. We did have a release from him, so we can use his name and his story. He was an incredibly beautiful human that touched a tremendous number of lives, and I'm going to try to do this without tearing up. Aaron came to our clinic in 2019 after being incarcerated He was a child of adoption. He started using heroin at age 13. So again, this theme of pre-developed brains being exposed to opioids. He actually lost a sister to overdose in 2006, and it was remarkable to me how confident he was that he wouldn't follow in his sister's footsteps of overdose in the middle of his substance use. So he was incarcerated related to addiction-related crimes. He'd been in for some period of time, I can't remember exactly how long, but a while, and had been complaining of pain and rectal bleeding for months and was not able to get any medical attention until he was out. He then was found to have a locally advanced colorectal cancer, fairly advanced. And he had been provided oxycodone for his pain and sent to me for management of his pain. And at the time that he had met me, he had resumed his use of heroin. So things that Aaron had going for him, he had some sober time in jail. That happened to be his only sober time in his entire life. So he had that idea of what it felt like to be sober, although in a kind of not great setting. He was extremely open about his heroin use and his history, an incredibly sweet, lovely, and vulnerable man. He had an incredibly supportive family, despite a lifetime of use and long periods of absence that caused worry. There was this open door policy that Aaron could always come back, and they had a family dinner once a week, and he would go for months and months and be gone and then come back, and they didn't require him to be sober. All he had to do was walk through the door. And that's a really unusual family setting. But they also had boundaries. So, there were boundaries around how that worked for the family. So it wasn't, I thought it was just really healthy. So he was open to supports in the community. He was open to partnering with me, similar to Lisa in the beginning. He was initially open to an opioid safety plan. He using methadone as a harm reduction and a goal to reduce his heroin use. And so this is a little bit of an unusual strategy that we started saying, hey, I'll continue prescribing, but I need a urine drug screen from you week over week. And that those heroin metabolites have to keep coming down. So we also did the same thing, delineation of duties with the family, as much non-opioid medication as possible. We actually had an impar block for him as an interventional strategy to help reduce pain, marginally helpful. And he did have an opioid agreement right up front, and we actually kind of re-modified his opioid agreement a couple of times. I actually like the way Housecall Providers does that rights and responsibilities document as opposed to agreement. We may be looking at shifting that a little bit. He agreed to continue in the methadone clinic. We wanted to address his anxiety because an anxiety component related to the cancer was very pressing and present. And we did connect him also to the Housecall Providers group, and Kelly will speak to her part of that interaction, or their part of that interaction with Aaron. Aaron continued to use heroin and was unable to bring those metabolites down and rely solely on the methadone. And so we ultimately had to stop prescribing opioids for pain management. But one of the things that was really lovely is that due to effective communication and care that had been developed through, previous patients, with dignity and empathetic care, he remained in contact with myself and everybody in the clinic during his treatment. And he'd go long periods of absence and still come back. And we just left this door open for him, similar to his family. He ended up with metastatic disease, and he would come in and get a scan, and then he'd get bad news, and then he would be lost to follow up for several months, and then he'd come back, and then we kind of repeat, wash, rinse, repeat. And he wasn't ever successfully able to get treatment for his metastatic disease. Again, the staff in this clinic, trying to hunt him down and trying to get him in and just rooting for him, was just so lovely and encouraging. So I think in looking back at Aaron, we're going to talk a little bit more about him, like I said, as we wrap up with Kelly and the question and answer time. I don't think that we could have done anything better for Aaron. I think we provided a great opportunity for Aaron, and Aaron was very open about, I just won't ever not use heroin again. And I know that that means that there might be consequence in terms of pain management and even end of life comfort and support. But he was very open that that was important to him. The emphasis on harm reduction was helpful in management of him for him, and the team was very engaged and empathetic. I think we could have possibly maybe brought his family in a little bit earlier than we did, and that was kind of a miss for us. For me, Aaron was a huge personal turning point for understanding harm reduction and trauma-informed care. His willingness to be authentic was such a huge teacher to me, and allows me to extend empathy into places I never could have before. So anyway, I will pass this on to Kelly. I'm excited for us to have a little bit of time in Q&A at the end, but thank you for listening.
Vanessa, thank you. That was absolutely wonderful.